Good afternoon. I'm Victor Schaffner, Director of Communications and Advocacy with the University of Delaware's Center for Disabilities Studies, and I want to welcome you to the Center's Lunchtime Learning Zoom webinar on Delawareans with Disabilities Accessing COVID-19 Vaccines. Thank you for joining us. It says a lot about the virus's continuing impact on so many people that today's event is attracting a larger audience than any lunchtime learning event hosted by CDS in memory. I'd like to introduce you to our panel of experts. Dr. Jennifer Horney is professor and founding director of the University of Delaware's Program of Epidemiology. She also is core faculty with the university's Disaster Research Center. Cory Nourie is Director of Community Services with the Delaware Division of Developmental Disability Services and is part of the Delaware Health and Social Services Work Group, aiming to ensure that vulnerable and difficult to reach Delawareans have access to the vaccine. She's also been the person designated to coordinate the response of DDDS to COVID-19, including vaccine distribution for direct support professionals and service recipients. Dr. Kara Ayers is Director of the Center for Dignity and Healthcare for People with Disabilities. Kara is also an assistant professor at the University of Cincinnati Center for Excellence in Developmental Disabilities and is part of a national effort to analyze all vaccine allocation plans related to disability factors. After Jennifer, Cory, and Kara make their presentations, there should be ample time for them to answer many of your questions. In fact, should there be a need, we may extend today's event 5 or 10 minutes or so past noon so they can get to as many questions as possible. Zach Davis, also at the Center for Disability Studies, will assist me in posing the questions to our panelists. If you wish to submit a question during the event, you can do so by going through Zoom's chat feature and typing or using speech-to-text dictation. Today's event is being live captioned, and we expect to post a captioned video of today's event to our website in the coming days. Lastly, at the conclusion of today's event, we will email you a brief survey asking you a few questions about the webinar. We ask that you complete it and send it back to us this afternoon. Thank you. And with that, I'll turn things over to our presenters. Dr. Horney, Jennifer.
Thank you for having me today. I just want to basically set the stage for our subject matter experts by speaking a little bit about the situation in COVID right now in the US and in Delaware specifically. So on the next slide, you'll see a tool that many epidemiologists use called an epidemic curve. And this is actually the global epidemic curve from the WHO website. And you can see here both cases and deaths that have been reported since nearly a year ago when COVID first came on all of our radars. And you can see the cases in the WHO region of the Americas and our recent spikes between Thanksgiving and the New Year, as well as our downward trajectory right now. So again, this is global data. So if we look at the next slide, we'll see the US data. And this is really important, I think, to look at these two different ways of presenting data because we have the count of cases. So that's the total number of cases in the last 7 days in the US. And so we expect to see the highest count of cases in the states with the largest populations. And that's what we see for the most part, although North Carolina is showing up there in dark as well. The rate of cases is actually more interesting from an epidemiologic perspective. And that's because we're looking at the number of cases per 100,000. So we can see there a higher rate in a couple of states, Kentucky, North and South Carolina, again in New York and New Jersey. These are just two ways of looking at the data over the last 7 days in the US. On the next slide, we can see what we've basically heard a lot about more recently, and we need to continue to understand, which is that COVID-19 has had tremendously inequitable impacts. So the risk of COVID-19 infection, hospitalization, and death is tremendously higher, particularly among African Americans and Latinos. So hospitalization, you can see, is 2.9 and 3.2 times as likely among Black and African American and Hispanic or Latino persons, and deaths is 1.9 and 2.3 times as likely. So we really are seeing inequitable impacts across infection, hospitalization, and death. So let's look a little bit at some Delaware information. So we've also heard, knowing those inequitable impacts in terms of infections, hospitalizations, and deaths, we've also seen that who is getting the COVID-19 vaccine is also has disparities in that. And so looking at this state level data from the Kaufman Family Foundation for Delaware, we can see that the share of the COVID-19 vaccinations that are being given among Black and Hispanic residents of Delaware is far less than the proportion that they make up of the total population of the state. So in the top graph, African Americans make up about 21% of the population, but only 8% of the vaccinations. And in the bottom, Hispanics make up about 10%, but only account for about 3% of our vaccinations. Next slide. So the Centers for Disease Control and Prevention at the national level, and Delaware and all the other states and those cities and counties that have their own health departments have set up their own framework for prioritizing distribution of the vaccine. And so you can see the links here to the CDC distribution as well as the Delaware plan. We're right now in 1B with a focus on those who are over 65 and beginning to work on frontline essential workers like teachers. And I think we'll be moving beyond into the rest of the essential workforce very shortly, depending on expanding vaccine availability. And so I want to just end by talking about what happens next. So I think there are a couple of really important things to follow. There's a new vaccine, the Janssen Pharmaceuticals Johnson & Johnson vaccine, which will be reviewed by the FDA in a session that's scheduled for this Friday. And more positive data actually came out today on that vaccine. I think it's really important to focus on the fact that in the clinical trials, this vaccine was 100% effective at preventing hospitalization or death from COVID-19. We're also having more data on the vaccines that we have been using to date. So the Moderna and the Pfizer vaccine, 2 small studies have shown that among people who've already had COVID, that 1 dose of these vaccines may be providing adequate immune protection. We don't yet understand how long that immune protection lasts, if it would last as long as the 2-dose vaccine regimen. And we're also finding out more information about the ability for those vaccines to be stored at regular freezer temperatures and for longer periods of time. So we know that one of the pieces that has been really difficult in this has been the logistics of distributing a vaccine that requires an extremely cold chain, and that we can't move around very much, and we have a very limited time to get that vaccine used once we've opened it. So I think we'll still keep our eye on developments that will expand our ability to use the vaccines we have now, in addition to getting new vaccines that only require single dose and don't require that cold storage. And I think the other important thing to remember is that we don't yet know about the vaccine's ability to prevent infection and spread. So we don't yet know about the vaccine's ability to provide what's called sterilizing immunity. So that means that even if you're vaccinated, you could still become infected with COVID but not become sick, but you could then spread it to someone who had not yet been vaccinated. and who may be more vulnerable. So that's why for now we have to keep wearing our masks, washing our hands, and maintaining physical distance even after the vaccine. This has my contact information, and I would be more than happy to contact with anyone after if there remain unanswered questions after the session. Thank you.
Good afternoon, everyone. I'm Cory, Nourie. Thanks CDS for hosting this. I'm going to speak today to kind of how we got into this phased approach for allocation, because I think that's a question that I hear a lot from both individuals and individuals with disabilities across the state. Just, how do we get to be where we are? So the history of how the allocation has rolled out is that there is a Federal Advisory Committee on Immunization Practices, which is known as ACIP. And they're using the data based on the coronavirus spread around the country and the risk factors and vulnerabilities to identify and prioritize people based on a variety of factors. And so ACIP has put forth these recommendations, and then internally within Delaware, we have the Division of Public Health, and we also have a Medical Ethics Advisory Committee who meets. And based on the ACIP's recommendations, the Internal Medical Ethics Advisory Group meets and discusses how the federal information, the data we're getting across the country, compares to the numbers in Delaware and the impact amongst Delawareans, both with and without disabilities. And so based on ACIP's recommendations, the Medical Ethics Advisory Group has met multiple times, and they edit and update the allocation plan based on the data we have available. And that's what we're calling this phased approach. So as Jennifer alluded to, we're in phase 1B right now. One of the things that I think is really important to understand about the phases is that we are doing what we're calling a waterfall effect. And so it does not mean that we have to get through the entire phase before we move on to the next one. So as you see right now, Delaware is technically in phase 1B. We are still in the process of vaccinating people who are part of phase 1A. So once we got through a bulk of 1A, then we said, okay, we have enough doses coming in that we can start to focus on the subsection of 1B, which is actually individuals 65 and older. And so that's where we are right now. And as Jennifer just mentioned, we are starting to ease into some of the other 1B personnel who are essential workforce. So that's grocery store clerks, people who work in the school system, frontline staff who work in firefighters and those kinds of response services. So what is happening is, as we are planning for the vaccine allocation, we are having appointments obviously being set up to try to reach people depending on which phase they're in. The great news is that people with disabilities fall into all of these phases, right? So we have, I can speak from the DDDS side of things, we have plenty of service recipients who have an intellectual developmental disability who are working as an essential healthcare personnel. So they were eligible under phase 1A to become vaccinated. The same is true for direct support professionals who work in our group homes or our shared living environments, as well as for paid caregivers who are providing direct personal care to individuals with disabilities. So all of those people were part of the phase 1A allocation. And so we are still currently in the process of vaccinating those individuals. At the same time, with phase 1B, we have a ton of people over the age of 65 who have disabilities who are already getting their vaccine because they're part of 1B being 65 and older. So we are working through the phases, and people with disabilities are included throughout them. As we move through phase 1B, focusing on the essential workforce, many of those providers, those employers will actually be working with local pharmacies to set up the vaccine sites. And it may be something as simple as having a letter from your employer that says, I am a 1B essential workforce employee, and then you can go make an appointment at pharmacy. As we move into phase 1C, which if you want to advance the slide to that one, this is where the bulk of individuals with disabilities, particularly for people who have an IDD or intellectual or developmental disability diagnosis, are going to fall into this category of phase 1C. So we are not there yet as a state in vaccinating people in phase 1C. It is, in the plans are in the works. And all of this is contingent on having actual vaccine to distribute. And so I know that's one of the frustrations that I personally am feeling, and I've heard, from people in the community day in and day out, and I understand that's frustrating. At this point, we are at the mercy of the supply that is available as far as having vaccines to actually distribute. And so the more vaccines that we get into the state, the quicker we can get through getting the vaccines out into the arms of people. So at this point, we have multiple plans in place to vaccinate individuals with disabilities. Again, for people who are part of the 1A allocation, there have been community events through the DMV, which we probably all heard feedback about back in January. I'm happy to say that, we have learned a lot from doing this week in and week out. And so I think the more experience we have in running mass vaccination events, the better we get about understanding and planning for it and trying to address the concerns and delays and that sort of stuff. So we've had the mass vaccination events. Just this week, the local pharmacies who are vaccine distributors are starting to actually get their own delivery of vaccine. So this will be a huge help for us in our local vaccine pharmacy partners in being able to actually vaccinate individuals who are in either 1A or 1B. For anybody who is participating who's part of 1A, if you haven't had your vaccine yet and you're trying to figure out how do I get access to it, it's probably going to require a letter from your employer explaining that you are a 1A essential healthcare provider. And then that should help you either be able to participate in one of the state-sponsored events or at a local pharmacy. For people who are in 1B, over 65, it's a little bit easier in that the documentation required is that you have to prove that you're over the age of 65. So for our community members who are over 65 who have registered on the state's portal, you went into the system back in early February, probably is when it opened up. And, we had 90,000 people register. Obviously the doses are coming in at a much slower pace than this, and we have to be able to get them out and get them into sites. So the process has been that based off of the availability of the vaccine and the vulnerability factors for individuals, as well as trying to make sure that we're equitable in reaching, as Jennifer alluded to, underserved and underrepresented populations, people are getting their invitation to register for one of those vaccination events. So if you have registered and you haven't heard yet, you are in the queue, and you should be paying attention to your email to make sure that when you get offered the opportunity, that you have a chance to connect for it right away. Additionally, I just want to lead into a little bit about the plan for 1C vaccine allocation. So again, here on the slide, you can see this is focused on individuals between 16 and 64 who have high-risk medical conditions, and specifically people with intellectual developmental disabilities are specifically identified there, in addition to severe and persistent mental and behavioral health conditions. Additionally, 1C also includes vulnerable populations who live in areas that we know have been a high risk for spread. And this would be congregate group settings. So this could be a situation like a homeless shelter. It also includes residential sites like a group home. So the plan for people from the DDDS network is if somebody is residing in a provider managed setting, we will have centralized events in each county with the providers where people will be able to come through and do a drive-through, honestly, and service recipients who would like to get the vaccine will have a chance to get their vaccine through one of those coordinated drive-through events. For individuals with intellectual and developmental disabilities who live at home in the community with their family or on their own, we have worked out a plan in partnership with DelDOT to actually be able to have paratransit vehicles go around and distribute the vaccine to people who are in hard to reach populations or hard to reach geographic areas. We have a lot of service recipients who, based on their vulnerabilities, haven't left their homes, honestly, since March 14th, almost an entire year ago, for fear of contracting the virus. And so we are working, we have plans with DelDOT to have the paratransit be able to deliver vaccines to service recipients in their homes. We actually are rolling it out initially with our 1B over 65 population for people, again, people over the age of 65, whether they have a disability diagnosis or not, who are vulnerable and hard to reach, maybe would have a hard time or don't have access to transportation to get to a local pharmacy. So we have submitted those plans, and it's just a matter of getting the the vaccine allocation to actually start that distribution chain happening for the 1B over 65. Again, for people in 1C, that's the plan for people who live at home. If they do not want the in-home delivery, that is completely up to them, in which case they would be accessing the vaccine through the local pharmacy chain. I was asked to also speak a little bit about some of the challenges and accessibility issues in people getting the vaccine and getting to vaccine sites. I want to just give a plug to the Center for Dignity in Healthcare for People with Disabilities, who on their website has a list of resources around COVID-19 specific things. There are a lot of resources out there geared to helping share information about COVID-19 as well as the vaccine to people in easy to digest formats. So there's lots of social stories available about the vaccine. There's lots of infographics, lots of different materials out there to help it be as accessible as possible for people to learn about the vaccine and be able to make an informed choice about whether they would like to utilize access to it when their phase opens up. Additionally, for people who are going to a physical location to get the vaccine, we've worked to make sure that sites are physically accessible for people who use wheelchairs. One of the things with the mitigation of trying to reduce the spread in a vaccine site is everybody has to be wearing their mask. Everybody has to maintain social distance. We have it worked out where people when they get their vaccine, then they go into the next room and there's a chair they sit that's 6 feet apart from the next chair, and you have to wait your 15 minutes for the observation period. As soon as that person gets up, we have the chair sanitized. So we have lots of practices in place to try to make sure that people who are coming together in person are being protected from the potential spread of the virus as well. And then there are also for DPH events, the Division of Public Health events, there are also assistive technology kits available to help people who maybe have some communication barriers. There is a consent form required for participating in a vaccine event. And so if somebody perhaps has visual impairment and needs to have a line marked, a hard stop so they can feel where they need to sign their name, that's something that's available that we could provide on short notice to somebody, as well as, people utilizing screen readers or magnifying amplification devices on their own cell phone. So there are AT options available as well. I think this is always an opportunity for us to learn to do better. And so if there's feedback about accessibility issues that somebody has, I think this is a great opportunity to share that with, you can share it with me. I'm happy to take that and to share it with the state, knowing that this is going to be, at this point, not a sprint, but a marathon, and making sure we get the vaccine out to every single person who wants it. Additionally, just before I wrap up, I want to just explain that if somebody was in phase 1A, and they at the time decided they did not want the vaccine, that does not mean that that is a forever no, you can't get the vaccine. You're allowed to come back as we move through the phases and say, I'm a 1A, it's been several months and I'm ready to have the vaccine now. They can still get the vaccine at that point. And I also just want to encourage people to have conversations with their healthcare providers about the safety of the vaccine in advance. If you come to a vaccine event and you want to ask a lot of questions about, is it safe for you? It's better for you to have that conversation with your healthcare provider, so that way you can make an informed choice and be able to plan for it accordingly, and not have you, get out into the situation and then realize or recognize that maybe it's not the right time for you. So I just want to encourage people to be planning for that. I think I'm going to stop there and hand it over to Kara, and then we'll answer questions. So take it away, Kara.
Thanks, Cory. I'm going to share my slides with you. All right. So my hope today, I'm Kara Ayers, and I am the director of the Center for Dignity in Healthcare for People with Disabilities. And so I was hoping to kind of widen the lens a little bit and give you some perspective about what's happening on a national level and some differences in state approaches that I'm seeing, so that, we can always learn from what's working and what's not. So Cory mentioned, I'm actually going to go forward here. So Cory mentioned the ACIP, which Delaware followed as guidance. And again, that's the CDC, so the National Advisory Committee on Immunization Practices, that got together in December and made these recommendations for priority groups. And so the Kaiser Family Foundation went through all of the state and territory plans and kind of counted how many used these ACIP guidelines as their starting point, and most states did. So like Delaware, that was kind of a starting point. And so, but there is still quite a bit of variation across states, and I'll talk a little bit about this. But so ACIP's general recommendations can be summarized with this slide. So phase 1A being those healthcare workers and also long-term care facilities. Again, some of the variability is in that some states actually prioritize long-term care staff in a phase before long-term care residents, but many did recognize the risk to residents as well and prioritize them in that first group as well. The ACIP recommendations included a focus on age, so people ages 75 and up were included in phase 1B, and then also ACIP recommended non-healthcare frontline essential workers. So again, grocery store workers, workers that are really out in the public with what they do. And then ACIP recommended people ages 65 to 74 and people with high risk medical conditions be included in 1C. So that was the starting point for a lot of states. And then it went from there with variability of different advisory committees and whatnot. So what we realized pretty quickly was that because of this variability, it was hard for people to find the information that they needed. And sometimes we need information not only about our own state. So we heard from people that said, well, I live in North Carolina, but my sister who has a disability lives in Tennessee, and I'm trying to make sense of this. So we teamed up, our Center for Dignity teamed up with Johns Hopkins University. Dr. Sweener there has a disability health research center, and so our small but mighty teams have worked together to create a vaccine prioritization dashboard, which I'm going to quickly drop the link to that in the chat box. And so what this is state by state, you can see things like what priority grouping did they list for people in long-term care facilities? What about other congregate care facilities? And then we realized that it was important to clarify how the states defined congregate care facilities. So some states did it really specifically, other states left it pretty broad. And we did the same for chronic illness. How does the state define chronic illness? Does the state include developmental disability in their prioritization list specifically? And if so, we've noted that. So we update this dashboard every Tuesday. So today you're seeing the newest, every Tuesday night we update it. So today you're seeing the newest grouping of states with their information and territories. And this week I will point out a concerning trend to us. So in the past, this is now our third update to the dashboard, I believe. And so in the past, we've been updating where states have actually moved people with disabilities up in their prioritization because they've heard from advocates that the risks for this population are so great that lives will be lost if we wait too far back in the process. But this week was the first time that we actually had some states, including Connecticut, that have deprioritized people with disabilities. And we have real concerns about that. Connecticut advocates are speaking out about how they feel that, different vulnerable groups are really being pitted against each other. So some advocates in Connecticut are speaking to some high-priced ads that were run across multiple media outlets that brought attention to the risks to teachers' health. And so some disability advocates feel that these groups were pitted against each other. And so, age was prioritized in Connecticut, and previously prioritized people with disabilities were pushed off the phases for now. So we hope that we don't continue to see a trend in that, because that's concerning for advocates who have kind of thought that their states had a plan that they felt like was equitable and sustainable, and now are worried that while they could be anticipating a vaccine in March or April, it could be kind of swiped out from under them per se. So we keep an eye on that for you for all 50 states and territories. And again, update the newest information is available every Wednesday morning for sure, usually late at night on Tuesday when we update it. So Cory provided an overview of Delaware's approach to this. And so really a little bit unique about Delaware is this addition of phase 2, which includes people ages 50 to 64, and then the ages 16 and up with moderate risk medical conditions and people living in congregate care settings. So some states don't have a phase 2, so that was somewhat unique. Some pros of Delaware's plan that I've also mentioned in national media when I've spoken about this is the simplicity and inclusiveness of the IDD category. So some states have gotten fairly diagnosis specific, which is concerning because rare diseases could be left out of that. You know, we have a data problem as was brought up previously. So it's not really accurate to say, you know, this diagnosis is the highest risk of all the diagnoses because we don't have data for most of the other diagnoses that you're comparing to. So, so we need to recognize high risk, but being broader in our categorization is a way to avoid further creating inequities and marginalization of groups within our disability community. The efficiency of rollout in Delaware is noted by data. And so a lot of the parts of the plan that Cory noted that have been considered, like transportation and how to get vaccines to people, that is so important. So that's why I kind of refuse to answer the question if sometimes people in the media who've been interested in our dashboard have asked, well, which state is the best? And there's not an answer to that because, you know, you could put people with disabilities, I guess, in 1A at the very front of the line, but if you don't have an efficient rollout and you leave people behind, then you know that's not necessarily best. So the efficiency of Delaware's rollout so far has been impressive. And again, just a recognition that people with disabilities are a critical population. It's actually specified that way in the plan, which is something that not all states have done. So that was admirable as well. Areas for potential improvement across several states, 1C is lower than many states. Again, it's not apples to apples because if you know, if Delaware is able to move through their approach with the waterfall, you know, approach with that, and they're able to get to 1C quicker than some states even get to 1B through 1B, then you know, again, it's not a apples to apples comparison, but 1C is lower than many states. Many states include people with disabilities in 1B. Um, there's, again, this is across most, if not all states, a lack of clarity for people who are not already connected to services. So if somebody has a developmental disability, but they're not connected to their DD services in any way, you know, how are they kind of found in the system, or where do they go? And again, we always have room for improvement for barriers like transportation, accessible communication. It sounds like there's been some fantastic cutting edge, you know, leading work in that area, but we need to continue to work on that. Oh, sorry, I want to make you dizzy, but, and just a really important and startling statistic that can't be lost in this is that people with disabilities in institutional settings, and that includes many congregate care settings, represent 40% or more of all COVID-19 deaths. So I think this stat is just, you know, alarming and urgent, and just really speaks to the fact that if we aren't prioritizing people with disabilities, especially those in congregate care settings, then we're not aligning to the urgency and the risk of loss of life for this population. So what the disability community needs, we need representation. It's abundantly clear as we look across these state plans that many of the advisory committees who develop them just lack representation from people who understand disability and see it as more than just a medical outcome. So people with disabilities are at risk for the, you know, and have been disproportionately impacted by the pandemic, not just because of our symptoms or our medical condition, but also because of, you know, poverty and transportation barriers and ableism in our medical system. So we really need better representation in these committees for a start. Addressing inequities. So I looked at so many state plans that would have a beautiful section on health equity that would never mention disability and would not include it in their conceptualization of equity or diversity. Again, it's still not recognized as it should be as a population impacted by disparities. We need practices that match ethical principles. So I read so many plans that said, you know, we develop these priorities with the top ethical principle guiding us is that we wanted to minimize harm and we wanted to minimize the loss of life. And if you look at that previous statistic I just shared, about 40% of all deaths being among people with disabilities in institutional settings, it just doesn't match up that if that was your priority that was guiding you, you made these decisions that put so many thousands of people ahead of people with disabilities. You know, we need better data collection that describes people with disabilities and their health outcomes. the data problem continues to be a significant one. Important points just to leave you with: we must increase the vaccine supply. I think all three of us brought this up. I know it's frustrating to hear it over and over again, but it's unfortunate that we're in this position where I say something like, thousands and thousands of people ahead, because everybody needs access to the vaccine. And I understand that everybody has their important reasons and their advocacy messages, but we've got to get that. So increasing the supply at this point is an advocacy priority, because without that, we won't get the access we need. Accessibility of the vaccination process is critical. Make priorities simpler, but not more vague. So I think Delaware has done a good job of leading in that effort. And again, consent still matters. Cory mentioned, a practical way to allow people who are blind to sign consent forms. Also, we're hearing concerning stories about people who've been restrained or given the vaccine against their will because a guardian wanted them to get the vaccine. There's so many ways that we can work through this process, through supported decision making, through positive behavioral supports, that restraint should not be, you know, anywhere in the front line of our approach to this. We at the Center for Dignity have a number of resources for people with disabilities and their families about COVID-19. We hope you'll go there. centerfordignity.com/COVID-19 is where we house everything. This is an example of a social story that walks people through what they could expect. This is just page one of it. There's 2 pages. We've adapted it in Spanish. We have versions actually now that are unique to some British terminology, jab instead of shot. We have Australia has just requested some adaptations. We've also put this social story in a video form that is narrated. So a person could listen to this. And sometimes we've heard from people that listening to it a few times kind of get some familiarity with the steps and knows what to expect. We know that the steps are different for lots of people. If you're going to a mass vaccination event, it'll look different, but the general steps are the same. So we've tried to capture that as well. And we really hope that you'll connect with us. Our information sharing is happening on a daily basis, and we're learning and sharing what we're learning. So we are active on Twitter and Facebook, both at Think Equitable. And then our website is centerfordignity.com. And if you're hearing what you're hearing today and you think, I want to join in these advocacy efforts, we have a work group that meets every other week. So we actually meet again on Friday at noon. We have people from all over the country, just like yourselves. There's nobody that would be attending this that we wouldn't have represented. We have self-advocates, family members, physicians, professionals, and we get together, we hear what's happening in other states, and we work on some of these tools together. So I really appreciate you joining for this discussion and allowing me to be part of it, and I'm welcoming your questions.
Well, thank you very much to all of our presenters. And we will now move to the stage of our program where we can pose audience questions to our presenters and get through as many of them as possible in the time remaining in our program. So this first question may go to Kara and Cory. You said in your presentations that Delaware recognizes the high risk of people with intellectual and developmental disabilities. Why then aren't they among higher priority groups in the rollout of the vaccine? They're grouped 1C and seem to experience more serious outcomes if they get the virus than many people in 1B.
Do you want to go first? I can start. I mean, from a national perspective, I would agree with that concern. Again, for me, it comes back to the efficiency of the rollout, though. Probably we do have to consider size of state. And again, my kind of theoretical guess on this is that if Delaware could get to 1C quicker than many states are getting through their 1B, then I'm not sure that the categorization, in a practical sense will come to mind. But I would agree with this comment that, yeah, the ethical principles that are guiding the plan don't seem to line up with the priority grouping given the urgency, and risk of loss of life.
So to address the point from the experience here in Delaware, again, the Medical Ethics Committee has following the ACIP recommendations. As Kara mentioned, people with IDD are specifically mentioned. That diagnosis is specifically called out for phase 1C, where other states haven't done that. I know in my conversations with other states on a regular basis, hearing about their phase plans, there are other states where people with disabilities are in phase 1A, but phase 1A has 4 million people in it. And I'm not exaggerating when I say that. So I think I hear the frustration, and it's absolutely true that people with IDD have been disproportionately impacted and the vulnerabilities are real. The numbers amongst service recipients who have tested positive compared to the general population are higher. And one of the things that Delaware did differently is, as you heard in 1B, there's a focus on 65 and up, where the federal ACIP had come in and said 75 and up. And that was based off of the data from Delaware about the incidence of people 65 to 75 who otherwise wouldn't have been categorized in that 1B. So it's based on the numbers and the data, and the Medical Ethics Board making the recommendations to who the allocation goes to in that order.
Okay, thank you. This next question would appear to go to Cory. Parents of adults with disabilities in Delaware spend many hours each day providing direct support and services to their adult disabled children. My wife and I are with our son 4 to 6 hours each day. Are we considered direct support professionals to him? Our tasks are identical to the services that would be provided by state resources if we were to fall ill to COVID-19 or become temporarily or permanently disabled. So the only distinction I see is that we are not being paid. Shouldn't we be included in phase 1C as DSPs? And if the Delawareans defining phase requirements for COVID-19 vaccine deployment do not want to recognize parent DSPs as real DSPs, would it be helpful if a joint House and Senate resolution were passed to recognize us as truly real direct support professionals?
I think it's an excellent, poignant statement. So the phase 1A addresses anyone who is an essential healthcare provider in a paid caregiving role. So we have many individuals with disabilities where they have family members who are paid to provide care for them. And so those family members, either through self-directed supports or PASAs or a variety of other programs, have been able to get the vaccine through phase 1A. For individuals who are in phase 1C, we are talking very vibrantly, for lack of a better word, about the impact of unpaid caregivers and their need to protect the individuals they love and care for every single day. So there are conversations, and I would encourage any kind of advocacy to continue to recognize that unpaid caregivers are providing essential services. And if something were to happen, as I knock on wood for you, that would be a significant impact for your family, and you're not alone in that. So I would encourage any kind of advocacy to make sure that people understand the full scope of service delivery, especially for unpaid caregivers.
Thank you. This next question would appear to go to Jennifer. What if by the time we're finally offered a vaccine, it's one of the vaccines that just offers 60 or 70% protection? Should we take it or hold out for one that offers greater than 90% protection? And even if we get the more highly rated ones, we keep hearing that you still have to wear masks and socially distance from others. If that's true, what then can you do after getting vaccinated that you can't do if you're not yet vaccinated?
I'm going to try and remember that mini-part question. So I think that it's very important to know that all the vaccines are very similarly effective. So the vaccines tested different endpoints. And if the Moderna and Pfizer vaccines, which are the ones available now, had been tested at the same time in the same populations as the Johnson & Johnson Janssen that's hopefully going to be available as soon as next week, that would have been a similar sort of protection. So that's why I also wanted to highlight in the slide that the primary thing that we want to prevent is severe infection. And so we want to prevent people from getting sick from COVID. We want to prevent them from going to the hospital. And we want to prevent them from dying. So I'm strongly suggesting that people take whichever vaccine becomes available to them as soon as they are in a group eligible to receive it. And I am cautiously optimistic that we have worked out a lot of logistical details, as Cory has said. Practicing this is, making us better at it. And that when we have a vaccine that's one dose that doesn't require this refrigeration process, that we're going to be able to do much more of the kind of large scale events at places like, the Speedway or other places where we can vaccinate a lot of people, and we won't need to worry about them getting a second dose appointment because they will get that protection in the single dose. And so as to so get whatever vaccine, there are no better or worse vaccines. Get whatever vaccine you can get that has been approved by the FDA under an emergency use authorization. And so I think the final question was about if we still have to wear a mask, what's the point? And so this is where I think a couple of things, there's a difference between public health and clinical medicine in the sense that every person we vaccinate gets us that much closer to some sort of herd immunity. And it will get you closer to being able to do things like, once everyone in your household is vaccinated, then, maybe you can do different types of activities within your household than you're able to do. And so again, the reason that we still want people to wear the masks and socially distant is because the end point in the trials was severe disease. So we're still analyzing the data, trying to understand how many people can still become infected with COVID. It doesn't mean they would be sick, they would not be sick. But they would still potentially be able to be infected. So we need to get every person that gets vaccinated protects our community that much more. And so it's really essential, I think, that people do that and we get to the point where we will be able to, to get out of some of these things. I also think it's really important to look at the data on seasonal influenza. And by wearing the masks and washing our hands a lot, we prevented a lot of deaths from seasonal flu. So there may be changes to the way that we do things and to the actions we're willing to take in the future in terms of mask wearing and things like that as well.
Thank you. Then this next question would appear to go to Cory and perhaps Kara as well. What should a person with a disability do if the request for accommodations at a vaccination site is denied?
So they should raise a lot of stink about that. I was trying to think of a better word. Yes, call CLASSY, so Community Legal Aid Society is one of the resources. I was gonna say there's a phone number. Laura just posted that in the chat box. Someone could probably pull the phone number up as well as for State Council. Thank you. Laura Waterland just posted it in the chat box. So it's the 302-575-0660. Thanks, Laura.
I would say it also helps, to know what accommodations you may need before you go, so that, and I think that's why we're trying to think about things like the social story or talking to others to know what to expect so that you can also be as prepared as possible. But it is frustrating because, like we've seen so many times throughout the pandemic, even when we think we fixed something at a policy level, if it doesn't trickle all the way down to the ground where people experience it, then those barriers remain. So yeah, so being aware of what you need before, I think, helps too.
Okay, thank you. I know that we have some other questions that are coming into the chat. I'll turn things over for a while to Zach Davis to pose some of those questions.
I saw one while Zach is getting queued up there that I think I can address. So someone asked, related to Cory's follow-up on the question of unpaid caregivers, kind of how can you advocate around that priority? And I would encourage you to look at states like California. Really had a good collective effort where they had some organizations that even scheduled some press briefings to educate the media about these challenges. And unfortunately, it's a lot of labor and it's a lot of work and time. But in answering your question about how do you advocate around this, I would look at the California advocacy community successfully, had their message heard, and some other states have as well. So education, I think, about exactly the way your question was phrased provided a good explanation about why this gap is problematic.
Thank you. Go ahead, Zach.
Thank you, Kara. Before I started with the questions, Laura Waterland, the director of the Disabilities Law Program, asked to please remind folks that individuals who are on Medicaid in Delaware can use non-emergency medical transportation to go to vaccine sites. So now to one of the questions. We've heard a lot about people aged 16 and up, but what about people under 16? What about children? So I think this probably goes to Jen. Why have they been prioritized lower? And what priority will they be?
Right. So the clinical trials were only the populations that were recruited in the initial trials only included adults over 18 or over 16, it's depending on if it's Pfizer or Moderna. So there are trials ongoing now for children over 12, so between 12 and 16. And once those are complete, there will be trials for younger children. As someone with 2 elementary age kids, I'm keeping a close eye on this. I think for young adult trials, I'll say that 12 to 16-year-old trials should be wrapping up quickly, because we were carrying them out over that Thanksgiving, Christmas period when we had a lot of cases. So it's actually it's a good time to be having a trial, because you have a lot of potential for people in the placebo groups to get the disease in question, and you can more quickly reach a statistically sound endpoint on that. So I do think that following that will be important, but for kids younger than 12, I think we're still going to be waiting a while.
And just staying on the topic of trials for a moment, have there been side effects observed specifically for people with disabilities, either IDD or other types of disabilities? And if so, can people find a list of those side effects anywhere?
Yeah, so I'm not sure about side effects that would be unique to people with disabilities. The overwhelming majority of side effects that have been reported through the CDC's vaccine reporting system have been relatively mild and similar to the kind of side effects that people report after other vaccinations. So muscle myalgia or muscle pains, chills and fever, pain at the injection site. And so you will receive information when you are vaccinated with a link where you can report any side effects, and they will actually, CDC will actually send you a text message or an email every week and ask you how you're feeling, to give any updates with your symptoms. But all in all, what we've seen has been mostly mild. Now, the thing is that mild for, me having fever and chills for 2 days may be very different than mild for someone with caregiving responsibilities, or someone with disabilities that would make it difficult for them to understand why those things were happening. So I think that we wouldn't expect the side effects to be any different, but the impacts that those side effects may have on people's lives for that day or two may have a different impact on their operational abilities. But again, with the reminder that these vaccines are highly, highly effective at preventing severe COVID, and that's what we really need to prevent is the type of cases of COVID that will put people in the hospital.
Thank you. Moving to Cory, people have been asking for a little more clarity about transportation, especially for folks who are homebound or who would have a lot of difficulty traveling to vaccination sites. So could you offer us a little more clarity on that process, especially for people who aren't registered with any of the state agencies?
Yep. So thanks, Zach, for that. And thanks for the questions. They're great questions. So as Kara was talking about, what about people who aren't registered, right? What about the person who has an IDD, who lives at home with their family and no one knows them, so to speak? So when phase 1C happens, there's going to be basically the announcement. So this is where, again, staying active on social media and staying active on the governor's weekly press conferences and through your local legislators. There'll be an announcement that we're moving into phase 1C. And so that, again, that diagnosis category of having an IDD is going, or one of the other conditions that's listed there, is going to allow someone access to the vaccine through their local pharmacy or through a local, if there's pods, the points of distribution happening, or a drive-up event, et cetera. We're also in the process, and I want to say it's actually happening this week, if not this week, then first thing next week, with having some mobile units, mobile vans going out to underserved populations, underserved areas, geographically distant areas, places where we know there's groups of individuals who are in phase 1A or 1B over 65 who can't get to a vaccine site for a variety of reasons. And so those mobile vans will be available in communities where someone can come to the van and get the vaccine and then go back to their home. So we are working through lots of different plans. And again, we have all these plans. The issue for us is that we don't have the supply to go along with that plan. And so I just wanted to mention, there was a question about, who's been representing people with disabilities on the medical ethics group and, who's been involved. So we have a work group within DHSS that with representatives from DDDS, from DSAPID, Division of Services for Aging and Adults with Physical Disabilities, representatives from Division of Services for Substance Abuse and Mental Health, DVI for Visual Impaired, the state service centers, the State Council for Persons with Disabilities. So we're all part of these work groups trying to reach and plan for how do we get access to the vaccine for hard to reach vulnerable populations. Additionally, from the Medical Ethics Board, if you go on their website, you can see their membership. They have members from the Developmental Disabilities Council, as well as federally qualified health centers and other groups, and they're public meetings that people participate in.
Thank you, Cory. To follow up on one of the points you made very quickly, if I could go to Kara. Cory mentioned the importance or the effectiveness of following social media closely. What have we been seeing in terms of outreach to people who don't have reliable internet connections?
Yeah, that has been another barrier. I think some people have been using their phones if they don't have, Wi-Fi for a computer or a laptop. But if you don't have access to that either, then you do need there needs to be some type of call-in option to get scheduled, and that needs to be made accessible to people as well. There have been some innovated kind of startups that just have arisen from the grassroots community. I've seen some again, websites that have pulled together waiting lists in some states, because you're seeing some instances of where, you may have heard about it in the news, where people have said, we have, once they open vials or they unthaw, they thaw out certain ones, they have so many hours to use it. And so some websites have tried to allow people to be added to wait lists as they come. So I do think that it's a good strategy to keep your eyes open if you do have internet access to social media and other ways that you can learn about what's going on. And, even after you get your vaccine, if advocacy is important to you as it is to me, continuing to make sure that these barriers come down for other people, I think is important as well.
Okay, thank you. I got some more questions on this end. This would be for Kara and perhaps Cory as well. It seems the allocation system favors people who are gainfully employed. If their profession is in a favored tier, they will hear from their employer about when it's their turn to get vaccinated and how to get it. For the unemployed, for a lot of people with disabilities who are unable to work and who don't live in congregate settings, they have to navigate the maze of pharmacies, clinics, and healthcare providers whose supplies vanish almost as soon as they appear. Can that be fixed? Is there a way to even the playing field?
I would agree with you. I think that it is problematic that again, it just doesn't match up. So if we state in our plans that our ethical principle guiding the priorities is reduction of loss of life and is minimization of harm, then it just doesn't line up from what we know about COVID, that we are prioritizing people based on employment status, or even based on just age ranges. So I think it's, it is a clear example of inequity in the way that we've approached this. And I think a lot of the state responses to that are, well, we were following guidance from the national, again, the ACIP led by CDC, which is led by science. But I think I don't find it an equitable approach based on what the science tells us. But, our country has also balanced throughout this process, getting back to work and our essential services and food chains that we need. And so all of kind of our weak links in our systems have really been magnified by this. So I'm not claiming that, my preferences, I guess, for prioritization are the right ones any more than, others are. But I do find it inequitable. I don't know that the climate right now is amenable to fixing it per se, because the only way you would fix it would be to get more supply and be able to actually give people access. I don't know that it does as much good to theoretically just swing open the doors and say, a free for all, because again, if you can't access it, what does that do?
Okay, thank you. Cory, this is to you. Does Delaware have plain language COVID materials to increase accessibility for people with intellectual disabilities?
We sure do. We have very openly borrowed from our friends around the country who have created materials. And so we have them available, I want to say, on the DPH website, as well as Kara has put some of the links into the chat box today. There are some materials out of New Jersey as well. And so there are lots of materials out there to help with accessible information about the vaccine.
And this next question is for Jennifer and Kara. Regarding people with developmental or intellectual disabilities suffering far worse outcomes as a population from COVID than the general population, is that simply because so many of them live in congregate settings, or does the data point to other reasons?
Yeah, I can start. That's a great question, a really important one. So there is the risk of the congregate care settings, but there's also a lot, the importance of recognizing that disability is more than just a symptom list. There is more than just the medical aspects of disability. So even those that don't live in congregate care settings, they may have direct support providers coming in and out of their homes and in and out of other people's homes. They may not be able to socially distance due to the care that they need or different settings or people in their lives. So, mask wearing, there may be a necessity to go to more medical appointments. But beyond all of that, we also have to look at, what we've learned. I think sometimes the media's portrayal of the disproportionate impact on people of color of COVID-19 has been misunderstood by the general public to mean that race itself causes, a higher vulnerability to COVID-19, when we have to look at the full package and realize that it's also systemic racism that has contributed to that. And the same is true with disability, that it's not just the diagnosis itself that causes a higher vulnerability, it's also systemic ableism and within our healthcare systems as well, which is why many people with disabilities, including myself, have not only been terrified of COVID, but terrified of the need to go to the hospital and be seen as a life worth saving with COVID. And so, we'll never be able to pinpoint exactly how many outcomes wouldn't have ended with death, had we not had inequitable healthcare. And I'm not, pointing to individuals for sure. This is a systemic problem, but that is definitely contributing, is that people with disabilities do not have equal outcomes in healthcare.
Yeah, and I mean, from an epidemiology perspective, I would agree with use the same concept with maybe slightly different words when we think about social determinants and the risk factors. So one big risk factor is living in a multi-generational household, and so by this definition, many people with intellectual disabilities will be doing that. I do think that Delaware is among the top. The states with the highest percentage of deaths that have been in congregate care settings, which I think, we could look at that as like we're doing a relatively good job in among, general settings of people, being relatively compliant with masking and these kinds of things. But it certainly is, a concern that it has been more, the deaths have been much more prevalent in congregate care settings. But again, it's not related to the fact that there is some sort of unique type of, and I think this also relates to the vaccination, right? Because as we've seen disparities in the distribution of the vaccine, we know, because we haven't, for the most part, gotten to those types of essential workers in which many African American and Latino people work, and so they haven't yet, been part of this scheme to do this. But thinking about the social determinants and particularly around housing and transportation and access to care, I mean, there are clearly factors in this.
Thank you. Zach, we have time for a couple more questions. What are you seeing in the chat?
So this, I think, goes to Cory. Just wondering if we can be sort of take a step back from these detail-oriented questions and tell people where specifically should they go to find this information.
So generally speaking, you would go onto the Delaware coronavirus website. That's being updated on a regular basis, as well as the DHSS Facebook page. That is, again, both routinely updated, kind of late breaking information. When there's a vaccine event, let's say that's been planned, and last week we had the snowstorm and things had to be canceled or delayed, the quick go-to information is available on the Facebook page for any of those kinds of late breaking information. The website itself has different, you can click on it and it says, tell me about this phase. You can click on that and it tells you about the different people and the eligibility for the phase and where we are in the planning, as well as registering for things like second doses and that kind of stuff.
And Cory, does that include tables or lists about where other than DPH people can go, people can contact to like pharmacies, doctors? Are those resources also available on the sites you mentioned?
Yes, so on the website, for the DPH website, it does mention the different pharmacies who have who are local partners now, who you can call to make an appointment with or go online to, as well as, I want to say, I don't, like the testing information is still available on there. You can make an appointment to get tested as well. So all those things are being updated on a regular basis. And Zach just posted the website there in the chat box. Thanks, Zach.
So it's funny because as you were asking that question, I was typing in the chat the Kaiser Family Foundation. So they compile a lot of data from a lot of states, including Delaware. And so then you're able to look and sort of see how are we doing and among different populations with related to disparities, both with COVID as well as with vaccines. So it's a good resource. And I would just also encourage people to find trusted resources for information about COVID and to try and be as optimistic as you can. I know it's really, really hard, but the supply is increasing and it will continue to increase, and it has the potential to increase quite a lot over the next couple of weeks. So I definitely know that lots of challenges with getting appointments and problems with how many, times can you refresh, and are you able to take off work to go get your vaccine, and all those many things. So I really would ask people's patience, and to know that we really are seeing a lot more supply coming, and the pace at which it is increasing is also positive.
Okay, well, thank you very much to everyone for submitting some wonderful and important questions to our presenters. We could go on and on with fielding many more of them, but unfortunately we're coming up at the time where we need to finish today's program. So a quick reminder to everyone that has been on this call that you will receive a survey shortly after we finish our program, asking you just a few questions about the program. We ask that you complete it and send it to us. By virtue of your having participated in today's webinar, you will also be added to our mailing list at the Center for Disability Studies, so you will be advised of future programming as it occurs. And I just want to take this time once again to thank all of our presenters today, Jennifer Horney, Cory, Nourie, and Kara Ayers. And thank you everyone for attending. Have a good afternoon.